Hi, and welcome to WomenHeart's Facebook Live on atrial fibrillation, or Afib. I'm Racine Tucker Hamilton, the Communications Director at WomenHeart. Heart disease is the #1 killer of women, claiming the lives of 1 of every 4 women. Afib is a type of heart disease. It's a problem with the heart's rhythm or the way that it beats. Today's discussion will be about Afib and women, its symptoms, diagnosis, treatment, early detection, and risk of stroke. So our guests today we're really excited. We have 2 members of our Scientific Advisory Council, Dr. Nanette Wenger, who is a professor of medicine at Emory University School of Medicine in Atlanta, Georgia, and she's also the founding consultant at Emory Women's Heart Center. Welcome, Dr. Wenger.
Thank you.
And also Dr. Annabelle Volgman. Dr. Volgman is professor of medicine at Rush College of Medicine and the medical director of Rush Heart Center for Women in Chicago, Illinois. Welcome, Dr. Volgman.
Thank you.
Thank you. And providing the patient perspective and sharing a little bit of her heart story is one of our Women Heart champions, Myra, who is from Louisiana. Thank you, Myra. Welcome.
Thank you, Racine.
So I think we're just going to jump right into the discussion. And why don't we start with you, Dr. Wenger, with just an overview of what is Afib?
Well, as you said, Afib is a problem with the rhythm of the heart, and it causes the heart to beat irregularly. This is why some patients may feel palpitations or the heart racing, but sometimes they feel nothing, and obviously that's a problem in the detection of Afib. But Afib is a problem also, in addition to symptoms, with the fact that it puts the patients who have atrial fibrillation at risk for stroke. And that is what we will be talking about, Afib and the risk for stroke.
Great. That sounds like a great discussion, Dr. Wenger. And I do want to remind all of you who are watching us on Facebook that we'd love to hear from you. We'd love to hear your questions or your comments. Just post any questions or comments you might have in the comments section of the Facebook feed, and we will get to them before the end of this segment. And if we don't get to them before the end of the segment, if we don't have enough time, we will follow up and post them on our Facebook page. So, Dr. Wenger, you talked a little bit about specifically what Afib is. Myra, why don't we start with you and have you tell us a little bit of your heart story and your journey with Afib?
Sure. Well, 9 years ago, I suffered a major heart attack. That heart attack left my heart with pretty significant damage, and I ended up with a diagnosis of congestive heart failure, cardiomyopathy, and coronary artery disease. So I was managing that pretty well. One day I was outside exercising. I was on the sidewalks in my hometown, and I immediately began to feel something go wrong with my heart. My heart started racing really fast. I started to get weak. I started to feel faint. And I was going to fall on the pavement, so I didn't want to do that. So I stooped down, and right before I got down, I've got an implanted defibrillator, and that sent a shock to my heart and put me back into rhythm. But I had no idea what had happened. Called my doctor, and he told me to go in. So 4 years ago, I was diagnosed with Afib.
Wow. And so that had to have been frightening, Myra, after first learning to live with heart disease, et cetera, and then to find out that something else was going wrong.
It was very frightening. I had no idea I was at risk for Afib. I did not know that because of my previous heart attack and the heart damage that my heart was at risk for Afib. So it was very devastating to get that diagnosis.
Dr. Volgman, why don't we talk a little bit about screening methods? Because like Myra said, she had no idea she was at risk for Afib. And according to the Centers for Disease Control, there are about 6 million people who are living with Afib. So what are some of the screening methods?
So that 6 million people living with atrial fibrillation are the patients that we know who have atrial fibrillation. And unfortunately, patients with atrial fibrillation can present with stroke as their only presentation. And so what we'd like to do is really screen people who are at risk for atrial fibrillation and potentially put them on blood thinners so that we can prevent a stroke before they even know that they have atrial fibrillation. The screening methods that we have are now various. You don't even need a doctor to be screened for atrial fibrillation. So if you're having palpitations or feeling your heart racing, you can just buy a monitor that you can buy on Amazon or any online store that could monitor your heart for atrial fibrillation. The new iWatch 4 will have that ability to detect atrial fibrillation. So many different methods now, but a doctor could do many things, such as a monitor that you wear for 2 to 14 days or even 30 days to see if you have atrial fibrillation. It's important to know who's at risk for a stroke. So anyone who's over 65 is at risk for a stroke. Women are especially at risk for stroke, so we need to identify women who are over 65, who have high blood pressure, atherosclerosis like heart attacks, and hypertension.
So, Myra, some of the devices and screening methods that Dr. Volgman talked about, do you wish you would have known about these things at the time when you were diagnosed with AFib?
Absolutely. I wish I would have known. I think that it wouldn't have hit me so hard when they told me that I did have AFib, because I had previous things and I just kept thinking, geez, not another thing to deal with. And I was worried about management of AFib.
And can you tell us a little bit about how WomenHeart helped you through this experience, helped you really perhaps understand the disease, get the support that you needed, et cetera?
Yes, so when I did learn I had AFib, the first thing I did was go to the WomenHeart website and educated myself. I found out what AFib was, what can happen when I'm having an AFib attack, maybe some of the lifestyle changes that I could do to help manage that. So WomenHeart was a great resource for me.
And did that lead to you becoming a WomenHeart champion?
I had, yes, that did lead for me to become a WomenHeart champion. I was so passionate about helping others learn about AFib and other things related to heart disease, and that's how I became involved.
Great, that's wonderful to hear. Dr. Wenger, let's go back to something that Myra had mentioned earlier. So she had a device after she had her heart attack and before she was diagnosed with AFib. What advice do you have for special populations like that, people who have devices?
Well, this is a very select niche group of people with atrial fibrillation, and they have, with their implanted defibrillator or their implanted pacemaker, they are constantly being monitored. So as their device is interrogated periodically, we can find out, are they having AFib? Is it consistent? Is it paroxysmal? What is their burden of AFib? And certainly there's not a problem with diagnosis or estimation of severity. But it's the vast majority of people out there who have the underlying risk of heart disease, of hypertension, of heart failure, who are candidates for AFib. And many of them, as we've talked about, have the heart racing, have the palpitations, but many patients are unaware of their irregular rhythm. So we're recommending that at every medical encounter, the doctors check the pulse to see if it's regular, normal, or if it's irregular, possibly atrial fibrillation. And with an irregular pulse, obviously record an electrocardiogram, or if the patient's suspected symptoms are there, as Dr. Volgman suggested, put the patient on a recorder or a monitor that can be done for various periods of time. I think this is particularly important for women. Again, what we tend to see is that men are slightly more likely to have atrial fibrillation than women. But because there are more older women and the occurrence of atrial fibrillation increases markedly with aging, there are actually more numerical women with atrial fibrillation. And we're seeing this in our population of older women, many of whom, as I've said, have hypertension, have heart failure, have coronary disease, or other cardiovascular disease.
Great. So I think let's have a conversation about some of the treatments and medications for AFib. And I do want to remind everyone who's watching us on Facebook to please send us your questions, share your comments. Just type them right there in the comment section in your Facebook feed. And we are going to save a little bit of time at the end to get to your questions. But Dr. Volgman, why don't we talk about some of the treatments and medications for AFib? Because Myra, you said you're managing your AFib with medication, correct?
Correct.
So there are two goals when you're treating atrial fibrillation. First is to prevent heart failure, which is another important consequence of atrial fibrillation. And to control the risk of developing heart failure, you need to control the rate or the heart rhythm. You can either stay in atrial fibrillation as long as you control the heart rate. And you want a heart rate less than 110 beats per minute at rest at all times, or without symptoms. So if you're still having palpitations at a heart rate of 110, you need to slow it down to make you feel better. So some of the medications that you need are what we call beta blockers. They slow down the heart rate response. Some are calcium channel blockers. There's a third one that I want to caution people they use against, because it's the cardiac glycosides, or digitalis glycosides, which have been associated with increased mortality or breast cancer. So especially in women, I really would prefer not to put them on those medications, because it puts them at potential risk of breast cancer. So beta blockers and calcium channel blockers are really the drugs that we choose to slow down the heart rate. There are more complicated antiarrhythmic medications that people sometimes need to stay in sinus rhythm, because not everybody feel asymptomatic with the just slowing down the heart rate. So those are very complex, and we need to follow those patients more closely. And then, of course, the other big risk of atrial fibrillation is the stroke. And there are various medications that can markedly decrease the risk of stroke, up to 80% reduction of risk of stroke. And those are the blood thinners, the anticoagulants that we can use.
So for people who may be on blood thinners and say they have to go off their blood thinner temporarily, they have to have another procedure, or for whatever reason, they have to go off their blood thinner temporarily, what advice do you have for them?
So for patients undergoing any procedure or surgery, there are different recommendations depending on which anticoagulant they're using. But for the most part, it does not seem to decrease the risk of stroke if you put them on a blood thinner that you inject. We did a study to look at that, and you just need to stop the blood thinner for a few days and then restart this after the surgery or the procedure.
Okay. So Myra, can you tell us a little bit about what types of medications are you taking to manage your AFib? And did you have any lifestyle changes that you implemented as well? And what advice do you have for patients just in terms of being able to manage their AFib and to live with it?
Sure. I am on a blood thinner. I believe that I don't want to have a stroke, so I take my medicine faithfully, and I believe that it is protecting me. So I am on a blood thinner. I have implemented regular exercise into my weekly routine. I used to be sporadic, but now I try to be very purposeful in exercising at least a walk 30 minutes a day, at least 5 days a week. So I'm able to manage my AFib pretty well that way.
And as a WomenHeart champion, do you find that when you're out educating people in the community, or either hosting some of your support group meetings, that you're finding other women who have AFib? And is it a source of comfort for them to know, like, I'm not in this alone?
Yes, it is. For me, peer-to-peer support is extremely important. I was terrified when I had the heart attack, and I was even more terrified when I got the AFib diagnosis. But I was able to connect through WomenHeart with other women who had the same condition as me and who were living a pretty normal life. And that's what I needed to hear from women who actually were living it, who were success stories, because it is pretty scary getting a diagnosis, especially when I went to Google and I started Googling what is this and what can happen. And so being able to speak to other women who were managing this disease and still living a normal life was so valuable to me.
That's
and
great.
WomenHeart was able to give me that.
That's wonderful to hear. And knowing what you know now, Myra, is there anything that you wish you would have done differently, had a different conversation with your doctor, or any advice that you may have for people?
Well, I wish I would have known that I was at risk for AFib. I think it would have just softened the blow when he told me what had happened to me, and that hearing that I was at risk for a stroke was extremely terrifying. So I just wish I would have known that I was at risk. It wouldn't have changed the outcome, but I think emotionally I would have been in a better place because I struggled. I was managing my condition pretty well, my heart failure and all that, and then I get this AFib diagnosis, and this AFib kicked me on my butt, believe it or not. I was feeling bad, but when we got it under control, I started feeling much better. And I have made some changes. I've decreased my caffeine intake, alcohol intake, exercise regularly. So this is just to help me manage my condition a little better.
All modifiable risk factors that we should all be doing as women anyway. Dr. Wenger, what do you think is the role of a primary care provider in terms of either diagnosing AFib or screening for AFib?
Well, again, so many patients have their primary care provider as the individual they trust and see regularly. And it's simply checking the pulse at every encounter, as we discussed before. And for the women who have AFib and who are being cared for by their primary care provider, the discussion that they can lead normal lives once they are appropriately treated. We have to remember that women are at greater risk for stroke when they have AFib than are their male counterparts. And not only that, but the strokes in women tend to be more severe. So that stroke prevention becomes critical, and the physician has to review with the patient the use of anticoagulants. It is critical that these medications be taken daily, that there aren't any skipping times, and that becomes part of your lifestyle, but it doesn't interfere with your lifestyle.
Yeah. And I see you shaking your head, Myra.
Yes, I am very purposeful in I don't want to forget my medicine. I take it daily at the same time. So I just developed a routine where my medicine's near me at certain times of the day when I need to take it. In the evening, it's right next to my microwave, because the last thing I do is turn off the lights in my kitchen. So I've developed a routine to be able to take my medicine diligently.
Great, that's wonderful to hear. So it looks like we are getting some questions in, and our first question actually is for you, Myra. Someone wants to know, in what ways has AFib impacted your day-to-day activities?
Well, the biggest impact was my exercise. And I also was fearful that if I would exercise, that it would bring on an attack. That's because I guess I had the attack while I was exercising. So lucky for me, I was able to do cardiac rehab, and I learned a little more about what actually happens, and for the most part, it does not affect my day-to-day activities because we're managing it right now.
That's great. That's great to hear. And Dr. Volgman, for people who may not know what cardiac rehab is, can you just quickly tell us what cardiac rehab is?
So cardiac rehab is a systematic method that we've developed in helping our patients after a heart attack, after any cardiac procedures, people with heart failure, and now it's been approved for people with peripheral artery disease and heart failure. And they go to the hospital 3 times a week for 36 weeks, and they can get, for 12 weeks, I'm sorry, for 3 months, so that the nurse can monitor their heart rates, their blood pressures, and they get a lot of support from other people.
And are we seeing, are the treatments for AFib different for women than they are for men?
No, actually the treatments are essentially the same. But I think the concern is that more women with AFib are older than their male counterparts. And what I see as I see patients in the clinic is their concern with their being on the blood thinners, on the anticoagulants, and the potential for falling. And you know, people of older age are often told they're a fall risk. It may be that they look frail, etc., but I think the important thing both for patients and for providers to know is it's not as much the fall risk, but have you fallen? And if you've not fallen, there is less of a risk that you are going to fall. Obviously, you have to be careful in your routine daily activities, but it is a trade-off. And women are at such high risk for stroke, and the anticoagulants are so effective in preventing stroke that there is no question that the balance between stroke prevention and fall and bleeding is far outweighed for the stroke benefit versus the fall and bleeding risk.
Yeah, so if you have that fear, you really don't have to be overly concerned about it in terms of the fall risk.
Well, again, if you've not fallen, you go about your usual daily activities. Remember that usual physical activity is valuable in preventing fall risk. Your bones, your muscles are stronger, and you are at less risk of falling if you engage in regular physical activity.
That's a great reminder. Thank you, Dr. Wenger. So it looks like we have another question, and this question is, I hear about AFib all the time. How common is it? Do you want to take that one, Dr. Volgman?
So it depends on the population that you're looking at. The older people have a lot more atrial fibrillation than the younger people. So we can start looking at patients who are over 65 who have about a 4% risk of atrial fibrillation. And then as people get older, people in their 80s, they have a 10% risk of atrial fibrillation. So the older people definitely have a higher risk. The people who have heart disease, such as heart failure, high blood pressure, they're going to be at higher risk for atrial fibrillation.
As Myra was.
That's right,
Yeah.
Exactly. People with lung disease, they are going to be at higher risk. Valve disease, they're going to be at higher risk. So it really depends on the patient population.
So, Myra, after you had your heart attack, what do you wish you would have talked to your doctor about after you had your heart attack and before your AFib diagnosis?
Well, what I didn't know was that, like, I did know my heart attack was a plumbing issue. I did not know that I was at risk for developing an electrical issue, which is what AFib is, correct?
Yes.
Yes, so I didn't know that. So I wish I would have talked to him about, you know, the electrical side of my heart. I don't know that we could have done anything to prevent it, but I think I would have just been more educated.
And that's another question. Is there anything you can do to prevent AFib?
I think the control of the underlying cardiovascular disease is important. So control of the coronary disease, control of the heart failure, control of the lung disease, of the hypertension, because the better control of the underlying problem, the less the occurrence of the atrial fibrillation complicating this. But again, we must try to do the best care we can of any cardiovascular or pulmonary disease. Remember also, patients with sleep apnea are at increased risk for atrial fibrillation. So it's control of the underlying disease, detection of the atrial fibrillation, and then management of the rate of the atrial fibrillation, but most importantly for the patients at risk of stroke, anticoagulation that is regular and persistent.
Thank you very much, Dr. Wenger. So we are just about out of time, but before we go, Dr. Volgman and Myra, I do want to give you both an opportunity to just add any last thoughts.
There are some new treatments for people who cannot be on anticoagulants, so that we can now put a device in the left atrium to prevent the blood clot. So that's an exciting field in cardiology.
That's great. And Myra, what about you? What last thoughts do you want to share, particularly from the patient perspective?
Yeah, I think a great relationship with my doctor, you know, is key to helping me manage my condition. I do have a great relationship, and I regularly speak to him about knew what are the treatment options coming up. So I firmly believe that finding a good doctor and developing a great relationship is one of the things that's really important.
Yeah, and I think Dr. Volgman and Dr. Wenger, you all would probably agree with that as
Absolutely
well.
so.
And
Definitely.
taking your medicine as prescribed.
Yes.
I'm
That's
a very, very strong advocate for that.
Great, great. Well, thank you all very much. We do appreciate you taking the time and having this important discussion about AFib. And I want to remind our Facebook audience that we did get quite a few questions in that we were not able to get to, but we will answer all questions in the comment section after this segment ends. So again, thank you all for joining us as well. And if you'd like to learn more about AFib or WomenHeart, you can go to our website, WomenHeart.org. And WomenHeart is the first and only patient-centered organization that supports the more than 48 million women who are living with or at risk of heart disease. We support, we educate, and we advocate on behalf of these women. Thank you again for your time, and thank you all so much for your time as well.
Thank you, Racine.